Well, once again, thanks for everyone coming. I'm having a blast. It's going to be quite a letdown tomorrow when you guys are all gone. But I think my wife will be glad seeing me again. Basically, what I'd like to do is spend some time talking with you about autonomic regulation therapy, primarily showing to you that you can actually understand the mechanisms of it. And for me, it's very critical to understand the mechanisms for you to design the therapies appropriately. We just had a very good example of where one of the vagal nerve stimulations trials had problems. Yesterday, Dr. Zipes talked about another one with the baroreceptor stimulation. And the long and short of that, both of them basically had problems because they didn't understand what they were doing to the system when they started going into it. These are my disclosures. This slide here was actually updated this morning based on some of the talks we had yesterday. This is basically the model you've seen that basically represents about 35 years of Drews in my life, which indicates the cardiac nervous system as a function of the nested feedback loops at the level of the heart itself, at the interthoracic ganglia, at the spinal cord, brainstem, and higher centers. There are three major clinical efforts in terms of autonomic regulation therapy involving either the vagus, the spinal cord stimulation, or carotid sinus stimulation. And based on the stuff we saw yesterday, we see that there are new areas that we can actually modify the system, specifically using RTX to modify afferent information coming from the heart. And as Dr. Patterson was talking about yesterday, there's obviously a whole series of venues that are going to be opening up in terms of some CNS stimulation. The point being is when you modify any of these areas, you've got to look at it in the context of the whole. It's just, as Jim was saying, if you do it in one place, you're going to be impacting other, and I'm going to show you a lot of the data we've gathered over the years, which will help you explain those types of interactions, and how if you understand it, you can control for it, and you can control for it, and you can achieve your therapeutic objectives. First point I'd like to make for you is that when you talk about the potential for any type of cardiac pathology, you have to understand that there are both inherent and acquired factors. Inherent factors include developmental disorders, myocardial infarction. There are also acquired factors such as diabetes mellitus. As Shiv showed you this yesterday, the field of neurocardiology is predicated on understanding the interactions between the nervous system and the heart it regulates. And for that, you need to be able to monitor and record and quantify both sites. This is essentially the technology we are evolving now, which allows us to do exactly that. And I'm now going to go through a series of examples in terms of what goes wrong within the cardiac control systems and then what we can do to actually physically deal with that. And one of the stresses we're going to deal with is myocardial ischemia in the cardiac nervous system. This slide is a little bit simplistic for the crowd here, but the long and short of it is when you have an ischemic event, heart performance goes down, heart size goes up, heart work goes up. You get the angina, sympathetic responses, heart beats stronger and faster. That makes work go up, which is basically a vicious feedback cycle. And in addition to the potential for failure, you're also at high risk for sudden cardiac death. Now this slide here is an adaptation of some work that actually was done back by Lowell Stone about 40 years ago. And this goes to a point Dr. Zipes was talking about yesterday and some of the other speakers were talking about, is that there are inherent differences between people in terms of their response to stress. This is an example of some baroreflex curves that they did in canine models where they changed blood pressure and they saw how much heart rate changed. And what they basically found is that there were some animals that had very weak baroreflexes, there were some that had very strong, and actually after they did this initial assessment, they went in and produced infarction in these animals. They let the animals recover, and then 1 month later, they did an exercise stress test with combined ischemia, and what they basically found is that some animals died and some animals lived. Now, I want to add to this stratification in that it's just not susceptible and resistant animals. If you do a heart attack in one of us or in our experimental animal models, about 1/3 of the individuals will die almost immediately on reperfusion. 2/3 of the people will survive. Of those 2/3 that survive, if they have a subsequent event down the line, 1/2 of those are going to die and 1/2 are going to live. So you have 1/3 that are highly susceptible, 1/3 that are very susceptible, and 1/3 you can hit with a freight train and you ain't going to do anything to them. Some of the reasons I asked some of the questions of Dr. Joyner is because it's incumbent upon us as neurocardiologists is to figure out how do we predict which patient is going to act which way, and then more importantly, based on that knowledge, how can we then define an optimum therapy to reduce that potential? And I'm going to show you some of the options we've already developed. Over here is just an example here. This is a response in canine models to a 15-minute LAD occlusion. You can see whereas some mortality occurred during the occlusion, the vast majority of it, almost 40% of the animals died within a few minutes of reperfusion. All right, so how do we go about assessing these kinds of characteristics? Well, this represents our capabilities in terms of neural recording. We are very good at recording activity from intrinsic cardiac neurons. On the heart, we use these sharp electrodes. We've now migrated to linear microarray electrodes, and we're about to go to the plaque electrodes. And what you can see here, here's an example of electrocardiogram, left ventricular pressure, and this is activity from some atrial neurons. Up here shows we can also record from the middle cervical or stellate ganglia, and we can also go in here and record from the dorsal root ganglia, or not shown up here, the nodos. So we can actually record from primary afferent and efferent processing systems of the cardiac nervous system. We can do so right now over 8 to 10 hour periods. Our goal within the next 2 years is to develop the technologies to allow us to do this 24/7. So that's a big thrust of the Neurocardiology Research Center here. Drew showed this slide yesterday, and the reason I just bring it back up to you is for you to understand that the cardiac nervous system has memory. When something happens, it remembers that for a very long period of time. In this case, we did a 30-second LAD occlusion, and this is some activity recorded from the dorsal root ganglia neurons, which is the primary sympathetic afferent processing center. And what you can see here is even after a very short duration ischemic event, activity was very prolonged for a long time. This obviously has implications for angina, so on and so forth. But a short stress has a long effect. One of the effects of the activation of nociceptive afferents, which are the afferent population that Irv is targeting with his RTX, is that you get sympathoexcitation. This is a recording from a number of neurons within the middle cervical ganglia, which is a primary sympathetic projection to the heart. And you can see here in response to that ischemic stress, we get a significant sympathoexcitation, which actually outlives the duration of the occlusion itself. This is the sum total of the activity, where you can see going from a very low activity before the occlusion, you can see essentially about a 10-fold increase in that activity during the ischemic stress. All right, now recording nerve activity is fine. That is obviously one index. It provides us very useful information, but it's also good to get an idea of what's actually going on within the interstitial space. For that, we've used the technique of microdialysis. Lou Dell'Italia taught me this technique about 15 years ago. We've published numerous studies on it together, but what we essentially do is we go in and we put microdialysis probes into the ischemic zone, into remote areas, and then in between we do the same type of stress with coronary ischemia and recovery, and we look at the characteristics of catecholamine release. This figure here basically summarizes the changes in catecholamine release from the ischemic zone and the border zone in animals who either were able to survive the ischemic insult versus those that died. And what you can see is as follows. The ones that are the dark circle here, these are the animals that actually survived the ischemic insult. Here's the baseline catecholamine during the ischemic insult. You can see it going up about threefold. And then during the reperfusion, it comes back down here. During the ischemia, on reperfusion, it goes up a little bit. And you'll see you get fairly robust changes in both the border zone and the ischemic zone. The animals that succumb to that ischemic event with fibrillation, you can see that they tended to have higher increases in catecholamine release during the stress, and more importantly, on reperfusion, they got an incredible surge in catecholamine release. And this surge in catecholamine release was actually, you can see here, we went from a basal level of 500 all the way up to 4,000 here, and these animals, there's no points passed here because these animals died. So the greater the catecholamine release, the more heterogeneous it is, the worse the indication is going to be for your patient. All right, so how can we go about determining what levels of this neuraxis are actually involved in that catecholamine release? So this, what I just showed you here was a response from the intact animals. Now what we're going to do is we're going to start disconnecting various elements of the cardiac nervous system from higher elements above it. We're going to show you results from animals where we essentially disconnect the interthoracic components of the cardiac nervous system, leaving this extracardiac interthoracic ganglia and intrinsics intact. And then we're going to compare that to animals that are just functioning with just solely their intrinsic cardiac nervous system. We do this by a technique of intrapericardial decentralization. The black bars here represent the release in the normal animals. So as we just saw before, if you look at we'll stay in the ischemic zone here, as you go from baseline to ischemia to reperfusion, a very nice increase in catecholamine release in all areas, ischemic, border, and normal zones. When we then went and essentially decentralized the interthoracic components of the cardiac nervous system from higher centers, a procedure not that much different from what Dr. Shivkumar talked about yesterday for treating the supraventricular tachycardias, what you can see is we still got increases in catecholamine release in all three areas. So what does this mean? What this means is that the interthoracic component has the capabilities for reflexly controlling catecholamine release within the body, separate from the central nervous system. When we then take that procedure down here and we now decentralize the intrinsic cardiac nervous system from the rest of the body, you can see that the catecholamine release in interstitial catecholamine levels in both the normal zone and ischemic border zone and normal zone did not change. The only place it went up was within the ischemic zone. And so what this basically indicates is that if you've got the interthoracic extracardiac components, you get a release in all areas of the heart. When you get down just to the intrinsic cardiac nervous system, it's restricted to just that area. Probably the more exciting thing for me of this study is actually over here in terms of the mortality. And you can see here's some mortality in the animals when their neuraxis is intact. When we actually decentralize either the stellate or the intrinsic system, mortality rate went from 40% to 10%. So when we had a much more balanced release in catecholamine release across all areas, potential for sudden cardiac death was much less. Now, obviously, that is not a procedure you do lightly. We do it at UCLA for treating supraventricular tachycardias. I was interested in seeing if there was an alternative approach for this, and the approach we chose was spinal cord stimulation. We basically, with our parameters not that much different than what Dr. Zucker was talking about yesterday. You go at 50 hertz, 200 microseconds, and 90% of motor threshold. These are parameter sets which are consistent with the anti-anginal treatment in patients. And what we basically found, this just shows you how we put the electrodes in. You guys saw that enough yesterday. This figure here shows you what happens. You already showed this figure before. In response to a coronary ischemia, you get a nice sympathoexcitation. If you've got preemptive spinal cord stimulation in place, you'll notice that you still have basal activity, but activity doesn't go up with the activation of those afferents when you do the ischemia. So once again, we had a question over here, what is the mechanisms of some of the neuromodulation therapy? One mechanism of neuromodulation therapy is you quiet reflex processing. You don't shut it down. Now, but what you do is you have, when disparate inputs come in, the system isn't disturbed nearly as much. All right, this figure summarizes that data, and this actually brings out a couple points right here. This is actually when we were doing long-term recordings from stellate neurons before and after the onset of the spinal cord stimulation. This is a relationship to the cardiac cycle, and you can see before we turned on the spinal cord stimulation, there was very low levels of activity, all pretty much on the isovolumetric contraction phase. When we turned on the spinal cord stimulation, there wasn't much influence initially, but after time, we actually started bringing in additional neurons. So this point being here is that spinal cord stimulation by itself can actually change the dynamics of the neural activity. One of the characteristics, that's actually even the basal discharge, but the point I want to emphasize to you is before we had the spinal cord stimulation, essentially a tripling in activity in response to the ischemic insult. After we did it, it just goes up just a few percentage points. So you quieted the response. If you get less sympathetic activation and you're still operating against the same EP substrate created by the ischemia, less catecholamines are going to be beneficial to you. All right, when we actually looked at the catecholamine release before and after the spinal cord stimulation, you can see here's the control, here's the normal zone and ischemic zone, and basically in the presence of the spinal cord stimulation, we reduce the catecholamine release by about half. So that actually is, we think, mechanistically one of the primary reasons this is beneficial. Mortality on this aspect, when we did the mortality on that, once again, 40% mortality without the therapy, 10% with the mortality. To show that we're not the only game in town on this, Dr. Zipes talked about this study yesterday. This was the antiarrhythmic effects of the spinal cord stimulation in the setting of the reverse remodeling. So in other words, what they did on this study is they took the animals out to a certain degree of pathology, they turned off the pathology stressor, and they watched how fast animals recover. Now this model by itself will recover, will reverse back to itself. What they basically found with this is that in the presence of spinal cord stimulation, it recovered a little quicker. This study here, Dr. Zipes also talked about yesterday. In addition to the effect of spinal cord stimulation, essentially putting a governor on processing within interthoracic ganglia, it also has effects on the myocytes. And it turns out you see some data here from when we did either C1, C2, or high thoracic spinal cord stimulation. This was a 30-minute ischemic insult in a rabbit model. And as we talked about yesterday, the net effect of this is that you can reduce infarct size by about 1/3. We did some subsequent follow-up studies on these things, and we basically shows that when another effect of neuromodulation therapy is essentially you change the metabolic processing within the myocytes and you make them stress resistant. So sometimes I feel like a snake oil salesman. The neuromodulation therapy reduces potential for sudden cardiac death, it preserves myocytes, and it reduces arrhythmias. So it's a remarkable process. Now, the long and short of this, and what we've come to at this point, is that we've said that if you look at the cardiac nervous system in its totality, if you get imbalances in that system, primarily afferent mediated, what's going to happen is you're going to get reflex responses within the nervous system. During the progression of that disease, there are going to be functional changes within the intrinsic cardiac nervous system and in the myocytes themselves that will have big influences on the potential for arrhythmias and pump failure, and that we propose that dealing with these imbalances are a major target. What I've showed you is some things you can do with spinal cord stimulation. What I'd now like to do is switch over to the atrial fibrillation and now focus on the vagal stimulation potentials for it. And this is some work done from Shiv and the team here in terms of doing some atrial mapping and showing both the rotors and the focal drivers. And the main point I'd like to point on that whole problem paradigm shift. As I saw yesterday when they were showing you the data, when you guys are going in there and slashing and burning, what's your success rate with atrial fibrillation if you look 5 years out? Not where you'd like to be. You've got what is about a 40 to 50% failure rate when you look out down the line, even when you start putting in the ganglia ablations. What I'd now like you to consider is a paradigm shift using neuromodulation therapy. All right, this is it's also taken from some work we published about 1.5 years ago. And the reason I put this up is I want you to, first of all, appreciate that the intrinsic cardiac nervous system is actually quite a complex little structure, but it's got elements that we understand and we now can control. Basically what we do is we quantify the characteristics of the intrinsic cardiac nervous system by doing a series of tests, including touch, occlusion of great vessels, stimulation of primary autonomic inputs, doing LAD occlusions. We can look at them if they're cardiac or non-cardiac related. And the main point I want you to realize, this represented about 100 neurons taken from 8 different animals, is that there is quite a remarkable diversity in terms of the responses of these neurons. Green indicates those which were significantly enhanced, red indicate those were suppressed. And the main point of it is the long and short of it is we can actually either find neurons which are primarily efferent related, which means they respond to the autonomic inputs, that they are afferent related, meaning they respond to the touch or occlusion of the great vessels, or they are the convergent population, which is those neurons which are sensitive to both efferent and afferent possibilities. The other point to appreciate, even if you talk about the efferent neuron input, is that 14% are parasympathetic, 15% receive sympathetic, and 27% receive both. So there's a huge input of efferent and afferent input onto these neurons, and they really are functioning as the little brain on the heart. Now that we understand how those neurons function together, we've spent a whole lot of time in our career trying to say, okay, now let's put in controlled perturbations, see how the system responds, and then define specific innervation points we can go in to rectify that. One example of this is the stuff that Inder just talked about. The work we did in terms of defining how the vagus responded to vagal stimulation was fundamental to how Anthem was designed for controlling heart failure, and it had a very successful outcome. What you see here is another model system that we have, which is for reproducibly evoking atrial fibrillation. We do that, first of all, we record from the intrinsic cardiac ganglia. We then go in with a small bipolar probe, and we can activate these mediastinal nerves. And as a result of activating these nerves, we stimulate during the atrial refractory period with a short burst of activity, and we can generate atrial fibrillation with a latency of about 1 second and a duration of 30 seconds. It is a reversible model. It'll be stable for 6 to 8 hours. It is a wonderful model for looking at therapeutic interventions for treating atrial fibrillation. First couple points I want to make about that. First point I want to make is we've gone in, first of all, in animals. We've induced the atrial fibrillation. We've injected dye-I. We've put the animals back in recovery for about 4 days. And then we go in and look at the characteristics of the neurons in the intrinsic cardiac nervous system that we actually labeled. And what we basically find in here, here's an example of the PGP 9.5. Here's the dye-I injection, which we did here. And what we basically found is that in response to stimulation of these nerves, we label about 13% of the neurons within the intrinsic cardiac nervous system. So we're impacting a very small number of those neurons. If you look at the characteristics of those neurons, what you find is about 15% were chat positive, about 17% were tyrosine hydroxylase positive. The vast majority of them actually received inputs basically were both chat and tyrosine hydroxylase positive, and there were a small percentage that weren't. This is just some of the confocal images which allowed us to build that figure there. Now recently, we have just completed a study where first of all, we've gone in and characterized what are the neurons that we're recording from. So we actually define them. This is an example from one animal. We're recording 10 different neurons. We define them as, once again, the convergent, the afferent, the efferent, or the unknown type. This is the entire population here, and that definition was based on this response down here, which we developed in our JPhys paper about 1.5 years ago. And we can actually do correlations between the various nerves and show how these fit together, but that's for another day. What I'd like to show you is an example of what happens to this nervous system when you induce the atrial fibrillation. Here you can see, this is in the baseline condition, very low, as Dr. Shivkumar showed yesterday, these neurons have very low firing frequencies. In response to the mediastinal nerve stimulation, we woke up some of these neurons, and you can see that their activity became quite pronounced during the atrial fibrillation, and some of them actually maintained that activity after spontaneous conversion. When we went in and subtyped those neurons, what we basically found that the primary neurons that were increasing their activity were actually those which we define as the convergent neurons. Those are the ones that get both afferent and efferent control, although the afferent population also increased significantly. We can now go in and start to quantify what are the mechanisms associated with that. First of all, to demonstrate to you that it's neurally and synaptically dependent. This is the response to the ability to induce the AF before and after hexamethonium, the ganglionic blocker. After hexamethonium, it's almost impossible to generate atrial fibrillation in these animals. We did some initial work with spinal cord stimulation. What I'd now like to, which we basically showed was antiarrhythmic. I'd now like to show you the recent work we've done with vagal stimulation. In this case, here's the response you saw in this animal before vagal stimulation. We then stimulated the vagus for 3 minutes at a fairly low level of vagal activity. We turned it off, and then we reassessed the ability to induce arrhythmias. And you can see here that after just a short 3 minutes of vagal stimulation, our ability to induce atrial fibrillation was markedly truncated, in this case fully eliminated. And if we went out and looked at the characteristics of the neural populations in response to the mediastinal stimulation, what we basically found was as follows. We found that we saw a significant decrease in activity at baseline in the efferent neurons. More importantly, we found substantial reductions in the evoked changes in activity in both the convergent and the afferent neurons of the intrinsic cardiac nervous system. Overall, we were able to either prevent or blunt atrial fibrillation in 75% of the cases in response to just a 3-minute stimulation. Now, when we basically, if you looked at the characteristics of those atrial fibrillations, basically there was a decrease in in the ones that we prevented, obviously duration is 0. In the ones we mitigated, it was reduced in half. And the characteristics of that AF were essentially, in terms of dominant frequency, were essentially unchanged. More importantly, we tried to sit there and say, well, what's really going on with the network interactions within these neurons? So the best analogy I can give to you, if you're an EP person, is our nerve network acting as a rotor, or is it acting as a bunch of ectopic pacemakers? So what we did is we actually went in and did correlation analysis between the various pairs of convergent to afferent, convergent to convergent, so on and so forth. And the long and short of that is that when you get the atrial fibrillation, what happens is there's a substantial increase in the synchrony between the efferent and convergent neurons and between the convergent and the convergent. So it's basically a self-re-exciting rotor-type network to generate the atrial fibrillation. When we have the vagal stimulation in place, basically what we do is we prevent the synchrony that goes up as a result of that stress. Now, the other point is, which Dr. Arnold talked about yesterday and Dr. Kimber talked about, is the autonomic nervous system has memory. Don't think about it as a linear input-output system. Don't think about it as a system where every input's going to have a defined output. We are still very far from that point. But the point, if you got nothing else from Guy's talk yesterday, the point you should have gotten is that when you do a low-level stimulation, you can change the dynamics of how that system is going to respond for a long period of time afterwards. And this demonstrates that effect here. We actually looked at the efficacy against atrial fibrillation as a result of time after that 3-minute right cervical vagal stimulation. And you can see that on average, that 3 minutes of vagal stimulation actually had an antiarrhythmic effect for up to 26 minutes afterwards. So when you're defining your duty cycles and when you're doing it, you make sure that you take that into account. If you have a duration of effect for 26 minutes, if you want to keep that effect, you better start stimulating again before the end of that 26 minutes. That's probably one of the reasons that SCS study had trouble, because they finished and for 12 hours they left their patients uncovered. And when you have this neuromodulation therapy, leaving a patient uncovered would be the same thing if you had a patient who was only taking his drugs he's supposed to be taking twice a day, only took it once a day. He's going to have a huge problem in the off points. Overall, if you look at the various types of neuromodulation therapy we've looked at this is percentage that have atrial fibrillation in response to our stressors. When you give hexamethonium, it's obviously very effective at getting rid of the atrial fibrillation. If you do the spinal cord stimulation, you can dramatically reduce the potential, as you can with vagal stimulation. And it also has an advantage. This was a study we published last summer. One of the beauties of autonomic modulation, or autonomic regulation therapy, is that its efficacy increases with time. If you think about the patients being treated for angina, there are some patients that have been treated for up to 15 years effectively for the anti-anginal effects. If you think about the influences against atrial fibrillation, what we basically looked at here was we looked at the characteristics of AF in response to the mediastinal stimulations in control animals that received spinal cord stimulation for 3 weeks, and those that got 5 weeks, and actually it improved as we went further along. So it's not a therapy that's going to wear off. As we're getting to the end here, I'd like to bring up one point, sort of going back to what Inder was talking about in terms of why were there differences in the vagal stimulation studies that were going on here. This figure over here is a response surface from a group of 8 chronic canine models. They have both right and left vagal stimulators put in. This is only with the right vagal stimulation. We go in and we essentially create the response surface for those animals all the way from 0.25 up to 3.5 milliamps, from 2 hertz up to 20 hertz, and we look at the changes in heart rate. And from this, these curves, even though this one figure here represents about a year of work, but it basically demonstrates some very important points. First of all, as you said with Nectar, they park their patients at 20 hertz, about 1.2 milliamps. If you look where that falls on the response surface, you'll actually see that falls within a tachycardia zone. The tachycardia zone, some of the work I'm not showing on here, we think the tachycardia zone on it is because of afferent activation, which causes a withdrawal of parasympathetic efferent activity. It's not sympathetic mediated. We actually have prevented that. Beta blockade doesn't impact that at all. But when you stimulate any of these nerves, you're getting both afferent and efferent. So these patients were parked in an area where they really obviously didn't get much of an influence. If you look here, there's this little yellow line here. We call this the fulcrum point. This is an area where you're stimulating and you're really not getting bradycardias, you're really not getting tachycardias, but you're actually, if you go in and do the neural recording, you're actually doing a very good job of essentially modulating the cardiac nervous system to prevent it from being overexcited. When you do that, actually it has quite beneficial influences in response to stress. This is where Anthem parked their patients. The Innovate patients are actually off the scale right here. They're at a much lower frequency and a much higher intensity. The intensity here, which is sufficient to get you to the fulcrum point, is in a range of about 1.75 milliamps. So when I look at neuromodulation therapy, I want to know what is the optimum frequency, what is the optimum current that I can apply at the lowest levels to achieve my therapeutic gain, at my therapeutic options. And for us, operating at the 10 hertz point makes sense because if you look at the ganglia themselves, that's the area where you have essentially the optimum pre to post ganglionic synaptic transmission. If you go above 10 hertz, you really don't have much of a benefit. All right, so what we said from this is that the imbalances in the cardiac system, especially those leading to excessive activation, can lead to both adverse short and long-term effects. Stabilization of those influences as a very effective way of reducing arrhythmia potential and preserving myocytes. And the primary targets for these are actually down at the local circuit neurons. Lastly, progression of cardiac disease revolves both heart tissues and the nervous system. Traditional therapies, ICDs, ablations, and drugs have asymptoted, and this new field of neuromodulation therapy actually holds great promise in terms of the future for this field. And I'd like to bring that forward to when, as Shiv was saying, and Irv and I were, Irv and I were at the Spark Initiative 2 weeks ago. And the whole mission of the Spark is peripheral neuromodulation for control of disease. According to the senior people from NIH that were there, this is going to be a big push from NIH for the next 5 to 10 years. And I wish I am here to tell you that here we at the center are here to help you in that goal. We would love to collaborate with you with our overall mission to figure out what goes wrong and then how do we deal with it. And this is obviously the people, the last slide and this slide are the people that made it happen. And with that, I thank you again. I do have one further point as a little gift for you. At lunch, if you go out there, Julie has little thumb drives for you that have the meeting name on it. We were going to put the talks on them, but since some of you guys were so generous and put data on some of these slides that aren't out in the public realm yet, we actually decided not to do that, so you get a free empty thumb drive. If you see someone here that had a presentation you loved, feel free to go up and say, can I get a copy of that? I got a new thumb drive to put on. All right. I'd be glad to take any questions.